Welcome to our slide presentation all about atrial fibrillation. Atrial fibrillation is a cardiac condition that is characterized by disorganized electrical activity of the top chambers of the heart or the atria. As a result, the blood from the atria is not actively squeezed into the lower chambers or the ventricle, but passively drains. In some instances, this can affect a patient's cardiac output. Atrial fibrillation is a very common arrhythmia. 1 in 4 Americans will have a day of atrial fibrillation at some point in their life. 40% of people over the age of 40 will also have atrial fibrillation at some point in their life. 65 million people over the age of 35 have been diagnosed with atrial fibrillation. It is the most commonly diagnosed cardiac arrhythmia, but fortunately it is not life-threatening. It is an arrhythmia of the aging population, and 4% of people over the age of 60 have atrial fibrillation. Alcohol can be a significant contributor to atrial fibrillation. One alcoholic drink can double the rate of atrial fibrillation within 4 hours. Here at Spokane Cardiology, we have a team of electrical specialists. Our electrophysiology physicians include Dr. Harwood, Dr. Klein, Dr. Quasman, and Dr. Muehlheims. We have 2 advanced practice providers that specialize in electrophysiology, Nancy Vitello and Alia Solek. Present with a variety of symptoms when they have atrial fibrillation, but the most common symptom reported is fatigue, along with shortness of breath, sensation of heart racing or irregular heartbeat, decreased exercise tolerance, chest pain or discomfort, and excessive sweating. Some patients are completely without any symptoms at all. What causes atrial fibrillation or increases the risk of an occurrence? Let's start on the left side of this slide. Age is a risk factor because atrial fibrillation is more common in people age 60 or over. There can be a genetic predisposition to atrial fibrillation. Oftentimes a patient will note that their sibling or parent also had atrial fibrillation. Hypertension is a big risk factor leading to the occurrence of atrial fibrillation. Other cardiac conditions such as coronary artery disease, congestive heart failure, valvular disease, or congenital abnormalities of the heart can also increase the occurrence of atrial fibrillation. Our modern lifestyle, including excessive stress, inadequate sleep, or untreated sleep apnea, can increase AFib. Thyroid abnormalities, especially hyperthyroidism, but occasionally hypothyroidism, can increase someone's risk for atrial fibrillation. Certain medications, especially stimulants, excessive amounts of caffeine, can predispose someone to atrial fibrillation. Obesity is a risk factor because obesity also can coexist with untreated sleep apnea. And then certain drugs or substances such as nicotine, alcohol, and marijuana can possibly cause increases in atrial fibrillation. Let's spend a little time looking at the association of alcohol and atrial fibrillation. Excessive alcohol use can cause scar tissue to form in the heart and damage the electrical pathways. Excessive amounts of alcohol can lead to congestive heart failure, and congestive heart failure is a risk factor for atrial fibrillation. Alcohol is a dehydrating agent and can cause electrolyte abnormalities that can increase the incidence of atrial fibrillation. There have been studies that have demonstrated that 1 drink of alcohol can double the risk of atrial fibrillation occurrence within 4 hours of that drink. A New England Journal of Medicine study demonstrated a significant reduction in AFib reoccurrence in the study group who maintain abstinence from alcohol. We know that smoking increases your risk of lung cancer and also coronary artery disease, but there seems to be a correlation as well between smoking and vaping and atrial fibrillation. People who smoke increase their risk of atrial fibrillation by 200%. The etiology of this is not clearly known, but it may relate to the fact that nicotine is a vasoconstrictor, so it causes your arteries to contract, therefore increasing your blood pressure, and increased blood pressure affects incidence of atrial fibrillation. Quitting smoking not only reduces the risk of atrial fibrillation, but also lowers the risk of other diseases that can aggravate atrial fibrillation. How is atrial fibrillation diagnosed and evaluated? Well, initially you will have a physical exam and someone will listen to your heart and note that the heartbeat is, as we would describe, irregularly irregular. You will also get an electrocardiogram or EKG, which will demonstrate this irregular heart rhythm. Sometimes we will have patients wear a longer monitor for either 48 hours or even up to a month to try to detect atrial fibrillation. An ultrasound of your heart or echocardiogram is necessary to assess your chamber sizes, the overall squeezing function of your heart, and your valvular structures. Sometimes we recommend patients obtain a home device, such as a cardiomobile device, or utilize their Apple Watch, which can actually capture short electrical tracings of your heart rhythm and can be very helpful in diagnosing atrial fibrillation. We also check routine labs, including thyroid testing. We check for anemia with a complete blood count. We check kidney function and electrolyte levels. Also, but not listed here, we may recommend some type of stress testing to make sure that coronary artery disease is not contributing to your atrial fibrillation. There are many things that you can do right now that can help to reduce your incidence or risk of atrial fibrillation. Trying to get adequate sleep, at least 7 hours a night of restorative sleep, is very beneficial. If you have sleep apnea or risk factors for sleep apnea, talk with your medical provider to obtain a sleep study. And if you have sleep apnea, treat appropriately with CPAP or an oral device. Try to limit caffeine to 100 milligrams per day. Avoid things like energy drinks or herbal supplements that may have caffeine-type products. Avoid tobacco products or vaping, and limit alcohol consumption. Exercising daily with a goal of 30 minutes up to 1 hour of walking or stationary bike exercising is very beneficial for your heart. Losing weight through diet and exercise is always recommended. If your BMI is greater than 30, you are 2 times as likely to have atrial fibrillation. Alternately, people who shed 10% of their body weight are 6 times more likely to maintain normal sinus rhythm. Patients who are obese have increased risk of complications from cardiac ablation, which we will discuss a little bit later in this slideshow. Some people with elevated BMI do not qualify for certain types of medical procedures to treat atrial fibrillation. We mentioned earlier that atrial fibrillation is not a life-threatening arrhythmia, but there are definitely risks and complications of this rhythm. The biggest risk with atrial fibrillation is stroke, because blood can pool in the top chambers of the heart due to lack of forceful contraction. This can result in the formation of clots, typically in a part of the heart called the left atrial appendage. Those clots can then go to the brain or other parts of the body. Your provider will likely use a metric called the CHA2DS2-VAS score to calculate your risk of stroke to determine if you are a candidate for a blood thinner, and we'll address that more in the next slide. Slide portraying the CHA2DS2-VAS score. So each patient's data is plugged into this. If you have a history of congestive heart failure, you get 1 point, hypertension 1 point. As you age, your risk of stroke goes up. So age greater than 75 is equal to 2 points. Diabetes is an increased risk factor for stroke, so you get a point for that. If you've had a prior stroke or a prior blood clot in your leg or your lungs, that's worth 2 points. Coronary artery disease or heart attack is 1 point. Age greater than 65 is 1 point. We used to say that females had a risk factor of 1 point, but we've now realized in further studies that this is not necessarily true. Typically, when someone has a CHA2DS2-VASc score of 2 or greater, we strongly recommend a systemic blood thinner. At that score, the risk of stroke is high enough to warrant anticoagulation. Aspirin, Plavix, and other antiplatelet agents or natural agents that are touted to thin the blood are not adequate to protect from stroke related to atrial fibrillation. Blood thinners, such as direct-acting oral anticoagulants, are used for atrial fibrillation, and you may be familiar with these: Eliquis, Xarelto, and Pradaxa. Warfarin can also be used to thin the blood if patients cannot afford these agents or have another indication for warfarin, but warfarin does require frequent monitoring. Blood thinners must be taken as prescribed to adequately reduce the risk of stroke or TIA. If your CHA2DS2 score is low, a 0 to 1, you may need blood thinners for a temporary period of time for procedures, but not permanently. This is all evaluated on a case-by-case basis. There are many different treatment options for atrial fibrillation that can be discussed. Typically, we discuss medications. There are less invasive procedures, more aggressive medications, and more aggressive procedures. And we'll go through each of these left to right. Initially, we may use medications to slow your heart rate, beta blockers or calcium channel blockers. We also may recommend trying to convert your heart rhythm using a procedure called an electrical cardioversion, where we use an electrical current to jolt the heart under sedation back into regular normal sinus rhythm. Sometimes this is done in conjunction with medications and antiarrhythmics. Antiarrhythmic medications include what's listed here: flecainide, propafenone, sotalol, dofetilide, amiodarone. We'll discuss these a little more in the next slides. Ablation procedure will also be discussed in the next slides. Sometimes patients need pacemakers if they have very, very low heart rates, but pacemakers do not treat atrial fibrillation per se. And then, of course, we are always going to recommend lifestyle modifications and risk factor reduction. One of the important components of treating atrial fibrillation is slowing the heart rate. If someone's heart rate is too fast in atrial fibrillation, over time it's possible that you could develop a poor squeeze of your heart or heart failure. Our goal resting heart rate with atrial fibrillation is 100 or less. Medications to slow the heart rate work by slowing conduction of the atrial fibrillation electrical impulses from the top part of the heart to the bottom part. These medications include beta blockers such as atenolol, metoprolol, calcium channel blockers such as diltiazem or verapamil, and sometimes we even use digoxin. You and your provider will decide which medication will work best for you. A higher level of medication called antiarrhythmics can be used to keep patients in normal sinus rhythm. So they not only can slow the heart rate, but they convert the heart rate from atrial fibrillation to sinus rhythm. These include flecainide and propafenone, dofetilide, which usually requires a short planned hospital admission, where you receive 5 doses of the medication while on a cardiac monitor. Sotalol is similar to dofetilide in that it also typically requires a short planned hospital admission. Amiodarone is a medication that can be started as an outpatient. We typically utilize this for only short periods of time in younger patients, but it can be used rather safely in older patients. It does require maintenance labs, chest X-ray, and pulmonary function tests. A pulmonary vein isolation ablation procedure can be offered to patients and is done quite widely at our facility by electrophysiologists. After discussing different options with your specialist, it may be determined that this is a good procedure for you. Please copy and paste the below link for an overview about the ablation procedure. The Spokane Cardiology Electrophysiology team looks forward to meeting you, answering your questions, and helping you in your management of atrial fibrillation.